Hello, lab experts. Once again, welcome to the RoK Diagnostics podcast. In today's episode, we're going to talk about urine examination. If you've ever been to a medical doctor's place and you had problems of a urinary origin, you may have been asked to pee in a sterile container for some kind of testing to be done. What that testing was is what we'll talk about today, why it's important to do that testing, and also what are some of the ramifications, if we get to that point, of diseases that cause urinary tract infections. And to discuss this topic today, we are sitting down with a medical laboratory scientist, Faridah Mansur. How are you doing today, Faridah?
I'm good. That's fine.
Thanks for being here today. So tell us a little bit about yourself.
I'm myself Faridah. I'm based in Kaduna from Kwara State, Oyin local government precisely. I was born in Kaduna too. I schooled in Bayero University, Kano. I graduated in the year 2020, and then for that, went ahead to do my internship program in University College Hospital, Ibadan, from 2020 to 2021. And then after my my internship, I went ahead for my National Youth Service Corps in the state, where I was posted to Ekiti State University Teaching Hospital. I served there till July this year.
Oh, so just recently.
Yes. We're the one
And
that left camp.
how was it over there?
It was fine. They were nice, very educative. I learned a lot from them.
All right. Or did you do a lot of urine sampling over there, urine testing?
Yes.
On average, let's say in a day, how many samples would you get?
On average, we'll have like 30 to 50.
And you had a team of people taking care of it, or how was the process? So let's say I'm a patient and my samples, I give them, let's say, to a nurse, or did patients come and give you the samples directly at the laboratory?
No, it depends. There are most of the time they go to the GOPD. They do sample collections at the GOPD, and they send it straight to the lab.
All right.
So when patients come after after 3 p.m. or 2 p.m., that's when they will direct them back to the lab reception to collect the sample and to bring the sample, because the GOPD people must have them closed by then.
Yeah. Now, do you take samples at any time of the day?
We take samples around 10. First sample comes in around 10. The second set of samples comes in around 12. Then the last set comes in around 2. So when they come after those periods, that's when they have to direct them to the lab.
Okay, I see. But then aside from that, patients can bring their samples still at any time of the day. Because I know there are some labs where after a particular time, they'll tell you that they are not taking any more samples.
So I bring them to the lab. We have a reception. They attend.
Okay.
They'll drop the sample and pick it up and take it.
All right. And when the sample comes, usually what pushes the doctor to send people for this kind of testing? What are people usually suffering from?
It depends on how the patient relates to the doctor. Let's say, for example, now the patient comes in and they start complaining of painful urination, frequent itches in their private parts, stuff like that. So the doctor might, and then if, for example, doctor feels there are some kind of issues going on with the kidney, I also ask for urine examination.
Okay, so the sample comes in, and do you treat it differently depending on the reason it's sent, or is the procedure always the same from beginning to end?
Procedure is the same. You have to do the microscopic examination of the urine, the microscopic examination of the urine, the culture, and then the sensitivity, irrespective of diagnosis.
Okay, can you briefly tell us what those are? So the microscopic.
Okay. The microscopic examination just basically talks about physical appearance of the urine, what you can observe, like the color and then the appearance. The color can either be amber or turbid, pale amber, while the color can either be, I meant the appearance can either be turbid or hazy or clear. I normally write turbid when the urine sample looks cloudy and has some particles in it. When it comes to the culture, there are two major media that can be used. Either you use cleared or use a combination of blood agar and McConkey agar. The standard media that's been used for urine examination is the cleared. Why? Because it's allows the growth of a lot of organisms, and then it is less expensive compared to when you have to use blood agar and McConkey agar.
All right. Going back a little, when it comes to the samples that get into your lab, how are they brought in? Like, is it always in a sterile container, or have you seen some weird containers in the past? Or it's always,
There is
do all patients, how do I put that, respect the directions they are given, or do some bring sometimes the samples in containers that you have to ask them to take back?
Mostly the samples comes in a sterile universal bottle. The people in the GOPD are the ones to give the patient the bottle. There is control from there. So there's no need, they don't usually have issues with sample collection from the bottles. Samples and the bottles are given directly from the GOPD and then to the patient.
To the patient.
I will tell them not to open the bottle till they want to produce the sample to avoid contamination.
Now, you talked about different kinds of culture media that are used. So that's going to be, so at this point, you've done the macroscopic examination, you've done a microscopic examination also, I'm guessing. And so you are plating it, so you're putting the sample on some culture media. Now, why the different ones? So what do they do? Does it serve any purpose to have the different types?
CLED is the standard media used for the collection of used for the culture of a urine sample. Why? Because it helps to differentiate between non-lactose fermenters and lactose fermenters. It also has electrolyte deficiency, that is decrease in the electrolyte, which helps to inhibit swarming of Proteus species like Proteus mirabilis and Proteus vulgaris. And then it also contains lactose, which helps organisms that ferment lactose. It also has bromothymol blue, which serves as a pH indicator. So this helps to change the pH of the medium from blue to yellow when the medium becomes acidic. While McConkey agar is just differentiates lactose from non-lactose fermenters, and it also contains bile salts too. But when you combine McConkey agar and then blood agar, the cost of production will be more.
Okay.
So it's better for you to use cleared alone, which serves for both purposes, than to use blood agar and then McConkey agar.
Now,
for just economic purpose.
So it's cheaper. Now, when it comes to the clade, you've talked a lot about differentiating between lactose fermenters and non-lactose fermenters. Why is that important to do?
Mostly the growth we usually have on from urine samples, we have gram-positive and gram-negative organisms, and then the gram-positive is just staph aureus, while the gram-negatives we have coli, it could be E. coli, it could be Klebsiella, it could be Proteus, it could be Pseudomonas aeruginosa. So when it differentiates lactose from non-lactose fermenters, it will streamline the identification. It will help for easy identification of the organism. Yes.
Okay, so it allows you to classify the organism so that later on your job is easier.
Yes. So when you see the pigmentations of the colonies to be yellow, you'll be suspecting it to be either E. coli or Klebsiella. And then when there is no fermentation, there is no change in color, you'll be suspecting either Proteus, Pseudomonas aeruginosa. And mostly Pseudomonas aeruginosa usually comes with green pigmentation, and it has a fishy odor. So from there, you'll be able to know that this is what I have, this is what I'm suspecting, this is what is next. Now, when you have those of like the staph now, the colonies of the staph looks deep yellow, unlike the lactose fermenters that are just yellowish in color. And then the colonies of the staph are tinier than E. coli and Klebsiella. E. coli is big, but not as big as Klebsiella. And Klebsiella colonies are mucoid and large. So when you have tiny colonies like that of staph, you just know that what you need to do is just do your biochemicals, like do catalyst test, differentiate if it is staph aureus or strep. You get. So after the catalyst test, you can now go further to do the coagulase test to confirm if it is Staph aureus or other Staph species. And then when you have the other ones that are lactose fermenters, that is, you have E. coli or Klebsiella, you have to do further biochemical tests to check, like further biochemical tests like urease test, citrates test, and the triple sugar in agar.
Yeah.
From there, be able to detect if it is, to be sure if it is E. coli or Klebsiella.
So what I'm getting from this whole process is that by the time you've gotten here, you have a pretty good idea of what the causative organism for whatever the patient is suffering from is. But you said there is an extra step. You talked about sensitivity testing. So what's the role of sensitivity testing?
The role of sensitivity test helps to determine what drug will be effective for the patient, and it also helps to avoid antibiotics resistance. So when we do the sensitivity, we prevent introducing antibiotics that might not work for the patient. Sensitivity test just helps to represent what goes on in the patient outside the body. It's just like a way of depicting what goes on in the patient outside the patient. Since we have the different samples, we just inoculate. We make use of McFarland standard and small portion of the patient and the inoculum, and culture on an agar, that is Mulaintin agar. That is the standard agar that is used for sensitivity. So when we have cultured, we have made an inoculum on the Mulaintin agar, then we'll pick antibiotics and place them on the plate so as to see if it will work. So when we place those antibiotic discs on the plate that has been inoculated, we incubate in the incubator for 18 to 24 hours to see how the drug is effective on the organism being inoculated. The following day, after 24 hours, we just compare the diameter with the standard antibiotics sensitivity templates, because we have a range for sensitive, a range for resistant. So if the range you have falls within the sensitive range, then that means that particular drug works when you administer it to the patient. When the range falls below and within the resistance range, when you administer that drug won't work for the patient. So it gives like an insight of what happens when you administer a drug to a patient, and also prevent antibiotic resistance.
Now, the test, does it allow you to determine whether any antibiotic is going to work on a microorganism, or does it allow you to determine if a small set of antibiotics can work on the organism? And if it's a small set, how is that chosen? Like, how do you choose the antibiotics you want to test?
Can you repeat your question?
So for susceptibility testing, you are testing.
Yes.
So does it allow you to tell whether any sort of antibiotic can work against a microorganism, or does it just allow you to tell if some antibiotics can work against that microorganism? And if you are only testing for some, how do you choose which ones you want to test for? Is it random? Is there a particular process that is used?
The antibiotics helps to check if the antibiotic drug will work on that organism, that particular strain that is in the patient. You understand?
What I'm essentially saying is, if, let's say, we have a microorganism on a plate, and we want to do the susceptibility testing. Let's say on that plate, we are testing for something like penicillin, a couple of other antibiotics, right? Yeah. How do you choose the ones you are testing for? Is it always standards, like in the whole world, or how do you choose?
You have to choose first-line drugs first.
Okay, what do you mean by that?
First-line drugs, there are drugs that you have to use first before you move to the next stage, because their intensity is different. You understand? Their mode of actions are different.
All right.
So there are some that works on the cell wall. I don't want to go too deep. There are some that works on the cell wall. There are some that works cell membrane synthesis, and the rest.
Okay. Yeah. But I mean,
So
so the
you have to check.
the direction I was going was, so when you take, for example, here in Benin, you take some, let's say some people that are doing some antibiotic susceptibility testing, what they'll tend to do, from what I've seen, is that they'll first start with drugs that are common on the market here. So in some cases, you may have a doctor prescribing maybe the doctor knows the types of antibiotics that are easily available. And so what they'll
Okay.
do in the lab is what they'll try and test are some of those drugs that are more easily available at the pharmacies here, rather than just a standard panel of antibiotics.
Okay.
So not just based on the specific mode of action, or the mode of action, but also based on what's available around. Because there have been cases where people will do susceptibility testing for some antibiotics, but then later the doctors will complain that the antibiotics that they used are not antibiotics that are actually found easily on the market. And so the patients later complain about that.
Okay,
And
what
so,
we do, we always make sure that most of the drugs we use are commercially available, like
all right.
like ofloxacin, nitrofurantoin, ciprofloxacin, they're readily available. So that's what we use.
All right.
So
Now, have you ever gotten a situation where you've tested those and let's say everything is resistant? What do you do in that case?
you have to do that is most drug resistance.
Mm-hmm.
So you have to repeat the sensitivity. You have to repeat the sensitivity. You use, let's say for example, maybe you use first and second line drugs. You have to repeat the sensitivity using third line drugs. Probably the patients have been using first and second line drugs, and then the body got used to the drug. So you have to look for stronger version of the drugs that can be effective for him or her.
So normally, once you get the results, let's say you're in the lab, you've done everything, you've done your susceptibility testing, you've done, well, prior to that, you cultured, you grew the bacteria, you've done the macroscopic and microscopic examination. What happens to the results? Do you give them directly to the patient? Do you send it back to the doctor? What's the follow-up?
So after you finish up, you record the samples, you record the results. So make sure the results are reported in case of referrals and in case of follow up. So after recording the results, you have to take it to the reception. The patients will come to the reception with their evidence of payment to pick up the results. And then we also we use a system to send the result to the doctor too. Because we use LIS.
Okay.
Yes, we use LIS. We input the data into the system. We also send the results from our end to the doctor. We also send the hard copy of the result to the reception. So if the doctor has issues with his system and he couldn't find the results on the system, he can also ask the patient to come to the lab. The patient will just use the evidence of payment to collect the hard copy of the results in the reception.
Are there cases where the patients sort of come around and ask you to interpret the results for them? I know that in some cases, you may have some patients that try and do that. How do you gently ask them to go back to see their medical doctor? Because some can be quite insistent.
You usually have people like that come to meet you. Please, can you explain what the result is? So mostly when they come, we tell them our work is just to generate and to do the test. The doctor will explain to them properly what to do and how to do whatever is there.
Now, earlier on, we talked very briefly while we were discussing when we were discussing culturing about a period of 18 to 24 hours. Is there a reason why we are doing it for that period of time? Why not short? Is it possible to shorten it, or does it have to be within that range?
It has to be within that range because we incubate in the incubator for 18 to 24 hours at a specific temperature, like 37 degrees centigrade, so as to mimic what is going on in the body.
All right.
We also have more growth. If you should check less than 18 hours, you have, and there are some organisms that don't grow fast. You understand? So when you allow them to stay for long, like 18 to 24 hours, in that range, they'll be able to grow. You give room for minimal any infection that has minimal concentration of the bacteria. You understand? You give them more time to flourish for them to come up. and then you'll be able to see
Yeah.
them. But when you check less than 18 hours, you might not when the growth is not much, the growth and you might not see any growth on the plate. So it might give you a false negative result. So to avoid false negative results, you have to wait within that time range.
So someone who is watching this, who let's say is not necessarily an expert, but is wondering when they need to go to see a medical doctor to, let's say, have this sort of testing done. What are the symptoms they should be looking for to go to the medical doctor and then have themselves checked out?
Let's say, for example, the person is having abdominal pain, lower pain, then painful urination, probably discharge and itches in the private part, and then probably the urine is the color of the urine is very deep.
What if let's say someone is suffering from, I wouldn't say suffering, but the person tends to have a certain level of frequency of urination and all of a sudden it increases. Could that be a cause for concern, or is it just normal? Let's say they don't feel anything, but they see that they are urinating more often.
Yes. That's another one. In people that have infections in the bladder, they have frequent urination.
Yeah.
So that's it's fine for them to come to see a doctor.
Tell me, so what now? You said you just finished with your internship. So what are your plans now?
I just finished my national youth service.
Yeah, the National Youth Service. So what are your plans now?
Get a place to work. Then from there, I'll be able to save up some things and then further my master. Further my career for my master's.
Oh, you want to do a master's? In what specialty?
Yeah. Public health.
Oh, nice. Yeah, it's true that we need more lab scientists in public health, actually. At least that's the way I see it. The way I think about it is we need more people that have the technical background to also go into the field so that they can help the medical laboratory sector develop and be a lot more, I'd say, competitive in a sense, and also a lot more helpful. Because it's true that we need people who are technical and who are on the bench and working at the local level, but we also need people who have that technical capacity and can also see things from, let's say, a higher level at a more global scale to help effect changes the way it needs to be. But why public health? What interests you about public health?
And public health has a lot to do with relating with the general public. Like it's like a way of helping the less privileged, enlightening the public, helping them, all this NGO work that you have to like help people, like all these neglected tropical diseases, go make them understand the reasons why they have to take their drugs, make them understand, you ensure that they get the vaccines when they are expected to, and why we are pushing for this. And then when you look at the public health sector and public health is the kind of way for us to improve our health sector. So people in public health are like the forefront in helping to eradicate a lot of low-income diseases that we have, like all these neglected tropical diseases and the rest, like all the polio, TB, stuff like that. You know, when you have when you're into the public health sector, you'll be able to put in your best, put in your efforts into helping people and seeing. You're able to see that the health sectors are really, really working hard. When you're not in the system, you won't really know what they're doing.
Yeah.
You feel as if everybody's just picking up the money and the rest. You have to put in your strength, your efforts.
Yeah. All right. So thanks a lot for taking the time for speaking with us today, Faridah, and for talking to us about urine examination of urine samples in the laboratory. Your insight was interesting. I hope you'll be able to complete your plan and then go on and then study and then get your master's in public health, because we'll need more people like you here in the future to help the field develop and also to help people and make their lives better. If people want to get in contact with you, what's the best way of doing that? Let's say social media, online, or anywhere else.
And get in touch with me on LinkedIn.
Okay.
And Twitter.
So just at your name, Faridah Mansur.
Yes, Faridah Mansur for my LinkedIn account. Gmail to the same thing, but for my Instagram is Farida with FAREEDAH. Mansur.
All right, no problem. So thanks a lot again for being here with us today, and hopefully we'll talk to you again soon to talk more MedLab.
Thank you very much. I'm grateful for the invitation. I'm highly honored.
Thanks to you.